All right. Hello, everybody. Or
Hello.
hello there. Good afternoon or good evening or wherever you are in the world today. We are excited. Welcome back to another very informative session here as we continue to look at ways to address the racial disparities in cancer of the lung, or Project Radical as we call it. And I am Dante. I'm with the Fred Hutch University of Washington Cancer Consortium, Office of Community Outreach and Engagement, and my work is focused on cancer health disparities for African American and African descent populations. And I am honored to be a part of Project Radical, where we are looking to address inequities in lung cancer for communities of color. And we have some of the Project Radical team with us here today. Hi, Dr. Manley. Say hello to the people.
Good afternoon, evening. I'm Eugene Manley, and I'm the Director of Scientific Programs at the Lung Cancer Research Foundation. And so I oversee lung cancer grant mechanisms. And with Project Radical, I'm working on how do we work on building pipelines to increase minority scientists in the STEM.
Good stuff. Thank you. And so, well, looks like Dr. Moorhoff is here as well, who also brought us all together. And we thank him for being here a little bit. Do you have time to say hello, Dr. Moorhoff, real quick?
Yeah, I'm happy to say hi. Thank you. Thank you, Dante. I'll let you lead and I will be in the background today. My name is Morhaf Alashkar. I'm a family physician at the University of Washington, associate professor, also stage 4 lung cancer survivor. And I'm honored to be part of this space to bring attention to the disparities in lung cancer. And especially with this is a time where lung cancer is becoming a chronic disease, availability of newer treatment, and making them available to everyone, it becomes a key. Any work that advances initiatives to improve health without attention to disparities could contribute to worsening those disparities. And because I'm passionate about lung cancer as a survivor myself, benefiting from those advantages, I want to make sure that in my day-to-day work, in my day-to-day life, I am also participating in correcting injustices. So thank you, Dante, for leading, and I'll be in the background listening and learning.
No, not a problem. Thank you. And so not only are we, dedicated to addressing these disparities in lung cancer treatments and diagnosis pathways, but we are taking action in what we consider a radical approach. And so we already know that in the US, this issue disproportionately impacts African Americans, African descent communities. And so we are more likely to be diagnosed at advanced stages, and they are less likely to receive staging or chemotherapy. And as a result, we have higher mortality rates and our outcomes are just different. And so what we want to do is look at these inequities in access to treatments or things like molecular testing. Not only this, but the strongest and most important ways to address this problem is to bring the very community itself to the table as we look to address this problem. And so this is why community-based participatory research and community engagement is important, especially in our radical work, that we will examine the inequities that exist when it comes to molecular testing, for example, as a diagnostic tool. And so also today we have some special guests with us. We have Dr. Angela Hill, Professor and Associate Dean of Clinical Practice at the USF Tanea College of the Pharmacy of University of South Florida, who received her doctorate in pharmacy from Florida A&M and has postgraduate training in everything, her neurosciences, community pharmacy, long-term care, special areas, all kind of methodologies and other ologies that I just can't list off. But she also does important work in community engagement, where she serves as the project manager for We Care, which is a community-based participatory research entity within the College of Pharmacy. And it coordinates activities with the community to educate and collaborate with diverse populations. And that's important. It's one of our goals at Project Radical as a community-based participatory project. And so she helps to address those gaps in the disparities. And we also have the lovely Charisse, Queen of Overcome, and we'll find out later why we call her that, even though she doesn't like us to call her that, but I love to call her that. And Charisse is also a retired public school educator, and she retired to fight her stage 4 lung cancer diagnosis on all fronts. She's a faith-based author, advocate, grandmother, volunteer, and superwoman. She was diagnosed in 2014, I believe, and she received her master's degree in educational leadership from Western Michigan University shortly after, keyword after, being diagnosed with lung cancer. So come on, y'all, after diagnosis, and then you finish your master's degree, superwoman. So I want to first thank everyone for being here and our special guests, and we are excited to have both of you here. So let's start, I guess. So as part of radical thinking, to bring about change, our group proposes not only to highlight those voices impacted by lung cancer disparity, but to have them lead us in the understanding of the root cause of the problem. So this takes all of us. And so Dr. Hill, some of your work in this field is important, looking at the community engagement stuff. Could you tell us a little bit about your work with We Care and some of the work in the lung cancer disparity space as well?
Well, thank you first, Mr. Moorhead, for inviting me here. It's a
Absolutely.
pleasure to be able to talk to you. So here in Florida, obviously we're a snowbird state, and we get a lot of transplants and things of that nature coming here. We also have wonderful research institutions, and University of South Florida is nestled in Tampa, but we're literally having Moffitt Cancer Center in our backyard. We have an AHEC center on campus that, specializes in community education and things, particularly in tobacco awareness. We've got the VA across the street, but just wonderful health institutions. And so our dean, Dr. Kevin Sneed, established We Care, again, as a community-based participatory research entity that would try to help close the gap in health disparities, particularly in the marginalized populations. We have these wonderful research institutions with very talented researchers that have a disconnect when it comes to connecting with the community. And we know the NIH requires them to at least try to prove that they're recruiting diverse populations to participate in, but oftentimes they just don't get the piece that they need because they're not culturally competent and culturally trained. So one of the things we pride ourselves in doing is educating researchers how to make culturally almost sophisticated, approaches to approaching these different communities. And we have spent a lot of time doing focus groups and other interactions with the Indian, African-American, Hispanic, Latino, Nigerian and Caribbean, African, Native American communities, and it goes on and on. And our magic is through going through, civic and social faith-based institutions and just connecting with anyone that has ears about, the travesty of this. So in the space of lung cancer, we're fortunate that we have a very strong and healthy relationship with the thoracic and lung cancer department at Moffitt. And so what we have done is partnered with their community outreach office and put on, particularly since the pandemic, all kinds of virtual workshops, just first providing education and awareness, but then also pulling them in when we've done community matchmaking events with researchers and community members, or health fairs so that they can do lung cancer screening, making, again, all of our contacts aware of voucher opportunities to get the screenings, and then using entities like AHEC to, again, carry that message even further. And so we're really proud of that. We have an upcoming health fair scheduled out for April, but we have, even during the pandemic, we've done about 4 programs with Moffitt alone. We also have another national partner called 50 Hoops that specializes in the recruitment of African Americans in clinical trials for cancer. And they are one of our national programs. And so just recently, we did a program highlighting lung cancer, and we do a lot of follow-up to kind of make sure if our community members have questions about trials, that we're there to be a resource to answer them. So we don't just come at them just talking about clinical trial participation, but we try to give them other information. And the pandemic has given us a lot of opportunity to for them to know us and us to know them.
That's great. Yeah, I think the importance of the community engagement is extremely important. And I gotta tell you, when I first read the proposal for this project, the study, for example, it has that component in it that you look for, because a lot of studies will say, oh, we want to work in health equity. We want to work with communities and disparities and lung cancer disparities. And, one of the first things you need to look for, because I look at a lot, is, are you approaching the community? And I think that this project does that, engaging both patients and providers and bridging that gap. And I think how we can truly hope to change things is with the power of community and advocacy. So reaching out to advocates and having the patient experience as part of the solution is critical. And so the work that Project Radical itself does is the proposal to incorporate community and qualitative information from patient and provider experiences. And so, the research by itself has its own merit, but learning to incorporate the community and engage with them in the experiences, like with our research project, for example, that's the key. So, and I guess anybody else can chime in as well, but would you agree that having that community component adds merit to the study and helps it along?
Oh, definitely. One of the things WeCare has is a research review committee made up of community members so that they can kind of be the gatekeepers before researchers get to approach the community. We can, use them to give insights on, again, strategies and things to consider. And that allows, using that gatekeeper concept allows you to kind of build some of that trust that has dissipated, for multiple reasons, over the years, just between the university and the community and all. So that's I think very, very necessary. Yeah.
Absolutely. I want to pause and to welcome Dr. Maisha as well, who happened to pop in for a minute. I'm familiar with her work. She has a lot of good work. If you want to say hello to the people, I'm also a big fan of hers, although she don't email me back, but she's busy.
I was just thinking of that. I said, oh my gosh, I need to respond back to Dante.
No, it's okay. It was a total
fan.
It was a fanboy email, so don't even worry about it. You're good. So, and I also thought I saw Matthew Thompson there as well, who popped in to say hello. So yes. How are we doing? Project Radical is here, people. Thank you all for joining us. And so that work, like I said, in reaching out to patients, interviewing, and having them reflect on their experiences is important to collaborative research and engaging patients and advocates, like Sharice, for example. We want to get their stories and their perspectives. And it can help us to further understand and also bridge that gap between communities and providers. Not everyone has access, for example, to the same types of diagnostic tools, and maybe something like molecular testing can prove to level the playing field, and we want to examine that perspective and research this. And so how can we get the community involved is the question. Do you think that, and I'll pose this to maybe Project Radical, maybe Eugene, Dr. Eugene, maybe you can answer. Do you think that examining stuff like this or looking at the inequities and disparities that exist in diagnostic tools, do you think that can move the needle in lung cancer outcomes?
Sorry. So, well, if we look at inequities, there's inequities at all levels of the healthcare system, not just at the diagnostic tools. It's in the screening, it's in the treatment, it's in the surgeries, it's in the outcomes. And these are multi-layer problems that are, exacerbated by systemic and structural racism. And then you have a workforce that says they want diversity or they want diverse voices. But then if you look at the representation of many of these places that are treating these patients, you see no minority researchers, you see no minority clinicians. And so what this does for a patient is they're used to the old system where you're not going to be listened to, you won't hear my concerns, I have a question, and you just get pushed aside. And so there's a lot of distrust in minority communities. So it's not just a diagnostic test, it's we need to make the system recognize that minorities are patients, they have concerns, they're real people, and they should be treated like humans and not prejudged based on if they may or may not have good insurance, if they can pay the bill, if they will show up to appointments. And these are all barriers that impact screening outcomes. And then also because minorities tend to not like to share when they're in pain or injured, and there's a lot of stigma with lung cancer, but also other diseases. They don't want to share that they have issues. So you may be going through chemo. You don't want to tell people because you may not want to bother them. You don't want them to think you're weak. And so you have social structures in play as well. So it'll take a multi-pronged approach to really address it all, but you really have to do it with getting more diverse people in research positions because they'll be more likely to advocate for minorities in trials.
Great, thank
Did
you.
I even answer your question?
You did, and some. Thank you. So I appreciate that. So with this multi-pronged approach that you were talking about, would you describe it as, I don't know, radical? You see what I did there? I mean, you see what I did there? Okay.
Well, it would be radical. It'd be radical just to get more inclusion, more representation, more accuracy. I mean, even if you look at clinical trials, we see what's a population is about 14% Black in the country. And if you look at NCI's, the SWOG trials, they have about 9% Black participation in those clinical trials. But if you look at the trials run by pharma, they're about 2.9% Black. And so some trials, you may be lucky if you have one Black patient. So how is it that you can get a drug approved for a population that likely often has worse outcomes, but they aren't part of the study group and you aren't actively going out to recruit them? Or you may say, oh, well, they aren't going to show up, so we don't want to recruit them. Like, that's not what it's supposed to be. So you're supposed to go get them, but you have to show you are committed to those communities. You can't just pop up, hey, we are running a trial, show up.
Yep.
And like, we've never seen you. You've never showed that you've cared. So why all of a sudden are we going to trust you? So you have to build trust in these communities. And that's going to take time too, because, we have a history of medical not exactly doing great by minorities, whether it's the Mississippi appendectomy, Tuskegee, eugenics, which is unfortunately too close to my name. So
we'll hold it against you. Yeah.
I know, it's like,
yeah.
Couldn't they call it something else? But so we have to really, to really address, you need more people in there that look like the people that will care. I'm not saying that people that don't look like you will, but if more people look like you are in the system, then you're more likely to get people to advocate for the care you deserve. And, sometimes minorities have different things that, you aren't taught in medical textbooks, and you might not know it. And that doesn't necessarily mean it's bad, but it's like, there's certain, factors at play, and a minority doc would just automatically know to look for it. And some majority docs just do not.
Nope. Fair point. Understood. So, like, for example, Dr. Hill, talk to me about how organizations like We Care and their community engagement. So, for example, we have a study that we want to engage these patients, but as Dr. Eugene mentioned, the mistrust and things like that. But we also want to make sure we have an opportunity to engage with that community to share their experiences and things like that, because stories can be powerful. But how does the office like that use community engagement to kind of work on that mistrust and to kind of get us involved in these types of studies and research so that we can help kind of close the gap in these disparities and inequities?
Well, some of the things that we've done through We Care is, one, try to provide forums for us to get the facts out there. So like we've done workshops talking about the Tuskegee study, talking about the Henrietta Lacks issues and some of these other things that particularly for Black people, really kind of made us put the brakes on. But doing it with bioethics groups, like we have a contact or a connection at the Tuskegee Bioethics Institute. The University of South Florida has one as well. And then being intentional on who we're inviting to the workshop. So not only people in our database, but certainly politicians and political leaders that can certainly drive policy for some of these, kinds of things as well. I think that's been one thing that's been effective. The other thing is having what we call fireside chats with decision makers and people who are in powers or positions of influence. So we met with the Panhellenic Council before, definitely meeting with the chapters of the Divine Nine. We met with pastors of churches before approaching their congregations, but allowing them input on what they thought they wanted to hear. The data from our focus groups was really also very telling in terms of giving us insight on cultural innuendos, whether or not the matriarch or the patriarch is important and how you approach them, but then also relegating all of that back to researchers. But then if nothing else, messaging that these communities don't want you to come in and just look at them as rabbits, do your research and leave. You need to come with intentions of changing the community, making a difference, but showing that you care, before you want to, do this research that's going to only benefit, the university or the researcher, but certainly investing resources and time, into these communities. And so that has been a consistent theme that's come out of some of the focus group efforts. And Dr. Standifer actually was a part of a lot of that work early on that We Care did back when we were formerly had a health equity center in place. And the focus then was more so on cancer, whereas now we've kind of expanded to include other areas. But I think that has been some of the things that have worked for us. Yes.
I think that's good. And because we need that community voice. And I want to make sure we get, Sharice here as a perfect example of that. And thank you again for being here, Sharice. And your journey is what I would consider a prime example of the differences in experiences when it comes to patient experiences among lung cancer and Black, African American, African descent patients. And so if you could, talk a little bit about your experience and feeling as a person of color, feeling unseen or unheard while in that clinical setting, and how that can have a ripple effect on your care when it comes to your lung cancer journey.
First of all, I am in total wow and shock at the initiative that's going on with this program. And I'm like thinking to myself while you guys are presenting, where were you in 2014 when I was diagnosed, right?
I'm
like,
so sorry
oh
I was
my
not there for
gosh.
you. Oh my God, yes.
Oh my gosh, it would have just saved me so much headache from trying to figure out what the world is going on. So I do want to take us back. Well, follow me back to the hospitalization of the initial diagnosis that I had in 2014. So I'm literally laying there in the hospital, and okay, I'm a little bit of a diehard. I don't know what's going on. I'm like, come on, somebody, bring me my cough syrup. Bring me my cough syrup because I got to get back to work. Okay, I just started a new, I'm an administrator. I'm coming out of the classroom to do some big things. Give me my cough syrup. I need to get out of here. Okay. Everybody's saying no. So all of a sudden, all these doctors are coming to my room. I just had a hole punched in my back where they drained 1,700 cc's of fluid off of my lung. That's what was happening. My right lung was crashing. That's how bad I was. And it seems to me, it's like, okay, this could be serious, I guess. And so I'm typing stuff on Facebook, like I'm getting ready to have a VATS procedure. And so my cousin, who's in the nursing field, says, wait a minute, Sharice, what's going on? I didn't have anybody like that or anybody to call. So let's fast forward a little bit to the end of the 2 week. It was the hospitalist who had experience from a university. Okay, come on, a university healthcare, not the local hospital. See, I lived in a rural area. Okay, so the hospitalist came, held my hand and said, Sharice, you have cancer and it's spread. It's now in your pleura. And what we're going to do, and I'm like, oh, wait a minute. Oh, cancer. What's going on? I've seen people with lung cancer. I've heard about lung cancer, and there is a stigma. So thank you, Eugene. There is a stigma. So no, nobody wants to talk about that part, but I'm like, wait a minute, that's not me. How did I get lung cancer? So there was not enough information out there. I have not even heard of any cancer groups like longevity, like ALK positives. None of them existed. Nobody knew. The local oncologist came into the hospital because there were 5 doctors in the hospital at that time to give me my initial diagnosis. And that local one said to me, and I quote, especially after I had to start, you got to get out of the hospital, the emergency part of it, go to her clinic. And she said, look, Sharice, you have monkeys jumping around in your head. All of these questions that you're asking, you just need to come to terms that you have cancer, lung cancer.
Say it again. She said what now?
You have monkeys. You have monkeys
Interesting.
jumping around in your head.
Side note for the audience, I just want to tell everybody that in professional or serious situations such as this, correlating people of color with monkeys in any way, shape, or form is not really the best thing. It doesn't matter what the context may be. It's not really the best approach or the best use of language. I would just, sorry to hear that. Please continue.
So after I said, tell you what, I'm going to get a little bit more, I can't be aggressive. That's just not how, let me be blunt and, clear. Jackie Robinson movie, he said, look, I cannot get aggressive. I can't get angry. Not black woman. No, I have to stay calm. And I still have to get my questions answered. So one day I came into for my appointment, started giving my arm out for blood and going through the regular routine. And then the chemotherapy, my goodness, she put me on was lethal. It was hard. The inside of my hands were turning black on the inside. I said, please, ma'am, I brought in a piece of paper this time. And I took a lung cancer brochure out of her clinic and I opened it up and I said, okay, and then here's my paper. Here's this brochure that you have in your hospital or your clinic. Can you draw where my tumors are? Can you draw it for me? Here's a colored pencil. Here's a pen. Can you do that for me? Well, she took it out and started drawing dots around the outside of my lung, the pleura. And then she said, it's just messy all on the inside. Okay. Then I'm like, okay, but not okay. So here I am taking oral chemotherapy. Guess what I had to do? I listened to a voice inside and I just decided to go to a University of Michigan. And there I had options. They looked at my biomarker test that was taken. So I really, in your education, the We Care, Angela, I used to hear about We Care. I was a pastor's wife. My husband, he's taking a walk right now. He was a minister. So we had a We Care in court. So when I listened to you talk, but they just gave food to minorities. They gave food and soap. Okay. They did not bring in the medical aspect of it. So I'm like celebrating you. So, but if they did bring in the medical aspect, it would be great to have some advocacy, a voucher for screening and some kind of information that would have helped me get some questions, but I didn't feel right. So I kept asking myself and digging. And I wish, Dante, that it stopped there. I have many more situations where I had to be proactive for myself, even when the insurance changed. And they said, no longer will you get your targeted chemotherapy now that you're at University of Michigan. You don't have to do the intravenous chemotherapy. You see the port, it's gone too. So one oncologist said, put it in. Another one said, take it out. And I had to go back to the other one and say to the surgeon and say, take it out. Because the other one said, no, you don't need it. So there's that. It was so much that I had to stay on top of my toes, plus deal with fatigue, plus deal with calling for my medicines, plus dealing with the financial load that flooded me all of a sudden. It's like, no, there needs to be a better support, better screening, better boots on ground in our communities that will be there. I wasn't the only one that had lung cancer in that community. I know about 4 others. Isn't that scary? I can't say their names.
Very telling. Yeah, very scary.
But they were there. And I looked at them. Some are gone now. And I wrestled with survivor's guilt for a long time. But I do believe it takes a certain kind of advocacy to keep pushing. And I even heard one of the doctors say, and they looked at each other and they say, treat her like she's our sister. Because I had good insurance at that time. You know, treat her like she's our sister. Why did you have to say that? Why would a patient needs to be treated as if I was your sister? Does everybody get that? Your best, I guess, as a doctor? That's what it made me think as a patient. I'm thankful that he treated me as if I was his sister, and maybe he did some extra things on the inside when he went in for surgery. But that comment alone let me know that, this is going to be the fight of my life. It doesn't stop here. It doesn't stop here. And I'm not willing to die knowing that there are some other things out there, but just are not, you got to dig for it, Dante. You got to dig for it. It's not about teach a man to fish and he'll live for a day. Give a man a fish and whatever that quote is. Well, where do you fish at? So where do you fish at? And that's what I spend my full time trying to figure it out, because I don't feel like dying today.
Well, we're glad you're still here, and thank you for sharing that story with us. And ladies and gentlemen, this is why we say Queen of Overcome, because you truly have. And it's very telling that you would mention, and I quote, the fact that you said I've had to overcome many more situations is quite telling, and it speaks to the disparities in experiences that may exist among patients of color versus non-Hispanic white patients or other patients who have different experiences. And this is where a lot of the disparities lie at. I mean, you spoke to how the provider was dismissive of when you're asking questions, and there was a preconceived notion that you may not have been smart enough to talk about your situation, and then the whole issue with the quote unquote monkeys jumping around in your head. And this speaks to a lot of things that Dr. Eugene was talking about with mistrust and things with people of color or African Americans in a clinical setting. And so all of these things show themselves when we are looking at lung cancer disparities. And so I would say that based on what you've shared today and the community engagement stuff and everything that Dr. Angela Hill was saying, I think it's pretty accurate if I were to say when it comes to experiences of Black or African American populations in dealing with a lung cancer diagnosis and even treatment or survivorship, that there are glaring disparities in those experiences that affect overall outcomes. I mean, these are, we could say it's opinion, we can call it advocacy, but you are hearing it from people, directly. I mean, there's numbers on it. I mean, exactly, for example, Black African American men are 20% more likely to develop lung cancer compared to non-Hispanic white men. And that's just one example. You can look that up. So imagine you aren't even being made aware of the proper access to the tools and things that you have to help you with your diagnosis, let alone the things that you have to deal with as a person of color in a clinical setting. These can be some compounding factors. Dr. Maisha, did you have anything to add? I thought I saw you unmute. I'm sorry.
Well, can I add one more thing?
Sure, you can.
Also, real quick. I did hear someone mention the faith-based communities.
That was me.
Okay, awesome. In the faith-based community, the only challenge, because right now that's where I'm still at and I still work very hard. It is hard, y'all. It is hard to get them to see, like a support group, faith-based support, and understanding the medical initiative part of this. So many people, a few people just came to me and said, well, if you had enough faith, you wouldn't have to, just deal with the cancer. Don't say the word, you should have enough faith. And that's a myth that we have to rise above and overcome as a people. Yes, I believe in God answering prayers, but it's going to be through a community of support. It's going to be, I believe he gave gifts to men and women and doctors and researchers. We have to do this together. See, I'm sorry for some of the past hurts. I really am. But today is different. And I believe there's enough of us who do have a skill set. And I'm sorry, not everybody is willing to fight and read and write, put pencil to paper. I write almost every day. I write applications, I write grants, I write. And I'm sorry, that's not a skill set for everybody, but at the same time, don't throw everything off and say, well, God, just have faith and God will, he will heal you, but you got to believe it. And if I don't go to the doctor, or if I go to the doctor, then I don't have enough faith. We got to get rid of these kind of myths. It's too much. And so so on all fronts, I would like to fight cancer and bring all communities, amen. Sorry,
Amen.
here I go together. Let me stop.
Amen.
Thank you, Angela.
Yes, amen.
Amen.
100%. Oh, go ahead.
Okay, I apologize. Just as this time, the technology, the power went out and I started to talk, but I'm back. And so kudos to you, Miss Pompey. You are I just put the queen, crown back on and straighten it up, because you are queen. After reading your book, I think it's just what you exude is that your perseverance and your survivorship, your story, is within itself your testimony. And so whether you want to bring in God or not, he is here in this place. So I'm just going to place it at that. But I thank you so much. I thank you, Dr. Hill, my colleague, my mentor, my sister. So thank you all so much. And I'm just so elated that everyone is able to come this evening and talk and share, basically, and share, as Ms. Pompey talked about, is that she wished this would have been around in her time, I think in 2014, and even now, it is still not there. It is still not where we want to be. And so I say this professionally as a community-based participatory researcher, that we are there. I am committed to being iterative and situating myself and my place and putting my professional leadership and servitude on the line, being in barbershops, being in beauty salons, being in nail salons, being where the people are who are most impacted from this disease and from health, disparities. As Dr. Hill talked about, the medically underserved or the marginalized communities are there, whether they be, and it can cross all race and ethnicities. We're talking about income level. We're talking about insurance. We're talking about access and health literacy. So we are there. I'm connected with We Care. I've connected with Project Radical, and little did I know I would be speaking last Friday to 50 Hoops to talk about not only my professional commitment to Project Radical, but my personal commitment. As in 2020 of March, my husband was diagnosed with lung cancer and succumbed to the complications due to lung cancer this past April. So I am here for the fight. I put, as I said, my professionalism on the line, and continue to be of a servant, and to continue to work with all of the researchers here and colleagues to continue to bring that message, because we need to get it out there. Like I said, in 2020, my husband, we didn't know, and I met a cancer disparities researcher. I didn't know some of this existed. I had started We Care, but little did I know the tables would turn, right? And I would not only offer my education, but be educated about this particular disease. And I tell people quickly in my story is that, being in the hospital, diagnosed my husband was, and in the start of COVID, which added a whole nother layer, where he was in the hospital by himself for almost 10 days, being told he had stage 4 lung cancer after 2 months of a cough. It's like, whoa, what's going on? So I only communicated with him via cell phone. And his mind, even though he was married to 10 years to a community-based researcher, he was still kind of numb to what was going on. Mentally, he was not there. And so I asked to speak to the doctors who, I wasn't allowed for a few days to come in when they said that he was diagnosed with stage 4 lung cancer. And at that time, when they said chemotherapy is your only way, I said, no, it's not. Let me go across the waters, where I had worked as a research assistant at Moffitt Cancer Center, and found that there were other options, right? And this is a large urban area. So the hospitalists did not offer the genetic testing, which is very interesting. And he said, that is your only way. And so after, connecting with individuals at Moffitt Cancer Center, I said, oh, And I found out about genetic testing, and we did. And I said, we're going to continue with this regimen, because at that time, I'll talk a little bit about, and I've said this about, my husband was very, not very apprehensive about, clinical care and care in general. His family members had succumbed to lung cancer. Grandmother, his father had just been diagnosed 3 months prior. Aunt was diagnosed with lung cancer and had taken chemotherapy as a form of treatment, and they did not survive. So in his mind, he's thinking, what's the purpose of continuing, getting care? And I'm going to pass anyway. But I think the oncologist over at Moffitt Cancer Center that was of color and looked just like me and my husband, that said, I am going to do the best that I can do with what I know how to do. And that took a weight off of him. And he said, oh, right. Because again, it was that trust barrier that was eliminated, because on the other side, the hospitalists didn't look like him. He didn't really trust. So going back to Dr. Manley, I know he's probably talked a little bit about training and development for clinicians of color. And so whether it be in research or whether it be in terms of community-based and community engagement opportunities, it's an opportunity. I'm now at Morehouse School of Medicine, where I'm teaching first-year medical students about political determinants of health and social determinants of health and how this all relates, and also focusing on lung cancer. We're also focusing, the clinicians are thinking, wow, I'm working in an urban community, but I could be working in a rural area, Sharice, and I could be working in a place where someone comes to me. So where does that first stop in? Whether I want to be a dermatologist, plastic surgeon, how does that impact me? And so we're making it very relative to the first year medical students. And I am particularly there to talk about lung cancer. And so that is my purpose, I see, as continuing to spread it, whether I said, and I know how to go into certain areas. I know how to code switch with my anthropological training, and I know to go into to talk to the pastors and how to talk to them. And I know how to go into barbershops because of some projects I worked through. I know how to go into beauty salons. I know how to talk to the nail technicians when I'm getting my nails done. So those are skills that you need to have and you need to understand. And also just to add that you need to understand when we're going out, who you're representing. As Dr. Hill talked about, researchers, we often kind of, we get a little geeky and we get a little myopic in our thinking when we're saying, oh, I'm going out representing my academic institution, but you have to understand your positionality. And sometimes that institution is not very friendly and hasn't historically been, right? So we need to say, okay, well, I need to sit in this a little bit. So let me let you talk to me and I'll talk with you. So when I worked in barbershops there in Tampa, I used to sit there for hours. And those are conversations I sometimes I wanted to hear and sometimes I didn't. But those were places and spaces that I know that we could talk about prostate cancer with Black men and sit there and understand. And I saw them and they saw me as their sister or auntie or a cousin. And I saw them as my father, my brother, my uncle, or my deacon in my church. So those are things that we have to continue to break those barriers and continue to talk about, again, lung cancer, but begin to talk about conversations that traditionally haven't been there in Black churches, right? Haven't been there in certain cultural contexts, but we need to infuse that and understand maybe we have to surround it and situate it within other topics. I was asked to come and talk about mental health in my church. And so I talked about mental health, we talked about trauma, we talked about suicide, we talked about so much, and talked about lung cancer, talked about screening. So we have to envelop it, the particular topic, and so many other things, because we are dealing with multiple traumatic, sometimes experiences, life, right? On top of the things that were going on within the pandemic. But these are things that we can continue to push forward and move forward. And we have a generation of researchers that are starting to do that.
Well said. Thank you so much. I agree with everything 100%. I didn't know that Dr. Hill was your former mentor, though, so that's interesting. How's your mentee is killing it, Dr. Hill. I just want you to know. So
Oh, I know. I'm not surprised. It's so
you
funny.
should be very proud.
I am. She is, and I wanted to just add, if you would allow me, Ms.
Sure.
Moorhead, as her husband was being diagnosed, my aunt was also diagnosed with stage 4 and lived at the north end of the state. And she literally was coaching me through things that I needed to communicate to my aunt, because I'm a pharmacist. So I can talk to you all day about the medications, but psychologically, even as a health professional, you just get almost paralyzed and you don't know what to do. And I know my husband probably wouldn't mind, but we just found out in the last week, my mother-in-law now has it. And it's interesting that in talking to both of them, neither one said the doctor suggested clinical trials, anything beyond, like you said, the chemo and the radiation. And it was Dr. Standifer who said, Angela, make sure you tell her to think about trials, tell her to think about genetic testing, which is so important. My mother-in-law was losing all kind of blood. She was having issues with clots. She was having endoscopies, colonoscopies, the run-of-the-mill testing, and they never found out why she was bleeding, but no one nowhere said, and this is a person with, both of them were smokers, but in her case, nobody said, stop smoking. Nobody said, let's do some screening for cancer. Nobody. How do you have a patient needing blood transfusions, iron transfusions, and no one has done the appropriate screening for cancer, to rule out cancer? So one of the things I have to say is, and I too specialize in mental health. That's one of my allergies, Dante, is that we end up as a culture of people being so reactive. And we do, unfortunately, get these traumatic end of life diagnoses and you're so emotionally distraught. You don't think about the other things and the other opportunities to not die yet, as Ms. Pompey said. And so we have to be mindful of talking to each other and teaching each other and breaking down these taboos that when you get a diagnosis like that, it's the end of the world. So I am just so blessed to have met, Ms. Pompey. I understand why they call you an overcomer. I am just so blessed to have met, I don't know how to say his last name, but I think Mr. Morhoff. When I hear that you all survived, it gives me hope to be able to now say to my mother-in-law, because I've lost my aunt now, and as a pharmacist, I would say, if you need me to help you stop smoking, just let me know. I would give them information, this, that, and the other. But knowing that things like smoking are psychological, but everyone that gets lung cancer doesn't aren't smokers, like in Mr. Standifer's case. And so we need to be mindful of our lifestyle practices and our family history, because it is just so important. So I said a whole lot and I just kind of butted in, but I just had to say that. But I never said what the acronym We Care stands for, and it is Work Group Enhancing Community Advocacy, Research, and Education. And the name itself oftentimes does get confused with that same group that you were talking about, Ms. Pompey, that does give resources and foods out. But one of the things that we try to do is certainly let the community know that we care, and that it's not just giving you some things, it's tooling you with information, with strategies, with resources, because we do think that awareness, just knowing, is half of it. Just knowing and being aware is half of it. So
I do want to bring to light real quick in regards to, I think you mentioned something that was very important in regards to, I don't know what it was, but maybe when I say this, it'll refresh my memory. But along the cancer journey, when, because my biomarker said that my cancer was non-smoking related, I would need TKIs, and I found that out going to the university. So I had options. Okay, so even if it's late stage, the information to find that out it was not easy. It took digging. I already said that. But when I did not know this, my doctor didn't share with me, but I did trust my oncologist of 5 years that I first had. And I didn't know that my cancer was going to metastasize to the brain. When it did, the insurance changed. So I had to go, for whatever reason, the insurances said, oh, we used to pay for your TKI, now we're not. And you need to come up with $5,000 down, not down, but per month for your medicine. And I fell out of my chair in tears. But thank goodness there was a nurse there that day, because I was thinking about, instead of driving 2.5 hours to always go see my oncologist and do blood work, just to have her take it and we'll ship it there or whatever, however they do it as nurses. But she said, Sharice, she looked at me in my eyes through my snot cry. She said, you can play the game. You can use your intelligence to play the game. You have a roadmap. So see if there's whatever these vouchers are to get prescriptions. So you working at the pharmaceutical made me think of that. But then I had to go and fight to get I couldn't go that route a long time. It was going to end. They only gave me a couple of months worth or something like that. So I had to go talk to the governor, the governor or the Senate of my state. It was weird, but I was very proactive. I said, why is there a change in my insurance? Who changed the tier of this medicine that was in the same family? And we got that senator, got the pharmaceutical company that made that medicine on the phone. And literally within 10 minutes, they called back and said, Sharice, your medicine is approved. It's going to be, you can pick it up, blah, 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 and we'll mail it to you. Give me your mailing address and you're good. I haven't had problems in 5 years now on that same medicine. I just wanted to share that as a pharmaceutical. So there's different levels, and I'm thankful for you having the background that you do, and hopefully you will continue to be empowered to find out where all these barriers are, and that is keeping, because she said, Sharice, not everybody is going to fight. So whether and I did have a cousin who did smoke, but she lived 2 more years longer. So there is, and there is so much out there still that is not quickly shared. And I think we kept each other encouraged. And it doesn't matter. Anyone with lungs can get lung cancer. There are biomarkers. We need to get those tests out there. They need to know where to find this. I wish I had it in 2014, y'all, the knowledge that I have now. But today I was able to do some other things, and I'm planning for more. Y'all have given me and encouraged me even more to continue legacy building. If I go home tomorrow, I'm okay with that. And I know y'all know what I'm talking about. I'm okay with that. I think that I've done enough groundwork on this side for others to point them to the resources, show them where to fish, show them where the pond is at. Thank you.
Thank you. And that's our goal. You hit it on. That's our goal, Sharice, to uncover and address all these barriers that you speak to. We don't want anybody to have that experience that you had to go through, and all these stories and perspectives and experiences are part of a bigger picture. They're puzzle pieces that we bring together, and these inequities are that are leading to worse health outcomes in lung cancer. And so we have to connect community and researcher and provider, and to really address these issues. And that is radical change, that's radical thinking, and this is what we are set out to do. We know that there's not enough readily equitable access to certain tools and treatments, or things that aren't available to all patients, and this further contributes to further racial disparities when we see it, especially when it comes to lung cancer. And so we want to do the work, and we want to involve the experiences of all the community to address the problems, especially through CVPR and engagement, and through the research and through the work, and just having people like yourself share powerful stories. And that really makes, a difference. And so you're prime examples of the work that we are doing and that needs to be done. And so, you are the queen of overcome here, and you laugh when I called you that, or, but I'm very glad that you're here, and thank you for all that you've done. And so I did want to be mindful of everyone's time and just say, thank you all for being here, and for Dr. Hill as well for being here and for sharing your work. And of course, Sharice's story is very compelling. I'm also willing to bet money that she's not the only one. And so what other discriminatory or implicit or explicit biases can we uncover when it comes to cancer care and lung cancer treatment for African American, African descent populations? And how can we collaborate? How can there be a collaborative approach in research to help these issues? And here's, where we ask, you can check out our Facebook and our Twitter pages to learn more information about Project Radicals. And if you can, we ask that you make donations or just look or just spread the word. We are trying to contribute our own work to make meaningful change and to make radical change. And so I want to thank everyone for being here. Any last thoughts from Dr. Maisha or Dr. Eugene?
I also want to say a couple of words, Dante. If
And
you
Dr. Morhoff.
I
Yeah,
want to say
go for it.
thank you, Charisse, for sharing your powerful story and inspiring us all. Same thing, Maisha, Dr. Hill, and Eugene, and Dante, of course, for leading this conversation. Very rich and thoughtful. The amount of effort that empowered people like Charisse or Maisha are doing to get the best care is astounding. And with working full-time jobs, with cancer being an additional full-time job, this is not available for many people. That's where community is coming together to help and support, and everyone, really, every individual person from wherever they are, to address those disparities become really essential. I'm a physician, primary care doctor, but I was not offered molecular testing. It was only when another fellow cancer survivor who told me about molecular testing that I asked for it for myself. So this is happening, continue to happen, and this is painful. And again, it causes our survival guilt, as Charisse said. This needs to change. So the conversation that we're having, sharing this story, continuing to do this work, hopefully will inspire others as well, and we can make an impact. So thank you all.
I would like to compliment your group for the work you're doing. Thank you so much for allowing me to share the little insight that I have, and certainly the work we're doing with We Care. But this is so necessary. And certainly if there's any other opportunities for us to work together, Dr. Standiford knows where we are. So everyone be blessed.
Thank you so much for joining.